First of all, I would like to thanks for this kind invitation and also to congrats the whole organizer community by this wonderful virtual congress. In the next few minutes, I'm going to talk about minimal invasive techniques for cervical spondylotic myelopathy. This is my workplace, Mexico City, the ABC Medical Center. I don't have any conflict of interest. And to don't repeat, summarizing the evidence-based medicine, I could say that cervical spondylotic myelopathy is the clinical consequence for mechanical compression of the spinal cord. The main factors in the left side for the decision-making process are the compression vector, which can be anterior, circumferential, or posterior, the clinical severity from mild to severe in agree with the modified Japanese Orthopedic Association scale, the presence of deformity or instability, specifically kyphosis, flexible, fixed, or instability, the number of levels affected, suggesting for less than 3 anterior approach is the best, and for more than 2, posterior maybe is the best. The comorbidity associated, and also when we combine these factors, we can achieve the surgical possibilities for the patient. In this sense, the evidence-based medicine favors the posterior approach in patients with circumferential or posterior compression vector and patients with moderate to severe myelopathy without the kyphosis, preferably without the stability, sometimes with a little bit instability. The number of levels affected no matter, and is ideal for patients with this kind of comorbidity: OPLL, osteoporosis, carotid disease, and previous surgery. The posterior approach could be made by open or miss approach. If we choose miss approach, we are talking about specifically of 3 techniques: unilateral laminotomy with bilateral decompression, hemilaminectomy, or laminoplasty. All of them by tubular approach, microscopic assisted. So I'm going to talk about these techniques. The rationale is supported by anatomical studies showing that the third occipital nerve has a very important role in the occipital headache and neck pain following midline dissections of the craniocervical junction. So the peer is go paramedial, respecting the raphe, to respect the ligaments in the midline, to preserve the muscles and ligaments, to prevent a very painful post-op condition, and to maintain intact this contralateral side. And also for maintaining the stability and lordosis, preserving the contralateral ligaments, muscles, and capsules. The surgical position is important. I usually use a Mayfield health holder to maintain and modify the position of the neck properly, avoiding face and eyes injury. Discrete semifolder could decrease the peridural venous turgor, and my recommendation is don't flex or extend to prevent and notice damage of the spinal cord during the anesthetic procedure. The monitoring trans-op is absolutely mandatory in the 100% of the cases, and we need the fine-tipped instruments and tubular access system to complete the technique, including all kinds of the same instruments, angular, long, curve, compared with the open or traditional techniques. The bone dissecting tools are very important. In the selection, we prefer match head with a smooth tip to don't damage the dura, or preferably the sonopet. The ultrasonic scalpel is better to dissect the bone in these cases. In the selection of the approach, it's important that the surgeon have to stay in the side of the worst compression, usually the side of the radiculopathy. It's very important as a tip, don't use K-wires or progressive blind dilation with the tubes as in the past, because the risk of go into the laminas and compress the spinal cord or chop it. Very important is to understand that this aberrant microdissection following the direction of the muscular bundles, what is quite simple, including the trapezius muscle, the semispinal cervicis muscle, and splenic cervicis, and multifidus, until find the bone plane, as you can see in this very brief video. It's a 2 centimeters incision, and with the tips of the bipolar, I can dissect the direction of the muscle fibers, helping me with very small esophagus retractors. I can follow the direction of the bundles in a very nice way, and taking advantage to make a hemostasis in the veins or smaller arteries crossing the field. At the end, I can take advantage of the retractors to put the tube inside the plane and obtaining a very clean, deep field, identifying easily the landmarks, the interlaminar space, the facet joint, the facet lamino junction, etc. The second step is to drill the lamina, the inferior third, the upper lamina, and the superior third of the inferior lamina. It's very important in the learning curve to understand that we have to get the skills to move all the instruments inside of the very small working channels. So the next step is to identify clearly the surgical landmark, which are the midline, the upper and inferior lamina, the interlaminar space, and especially the laminofacet junction. Usually we put the tube taking all the interlaminar space and a little bit the facet joint. The craniocaudal and mediolateral winding could permit us a very nice surgical action field, bigger as we can imagine. Very important is to bear in mind the key goals of this technique, sparing the tension band and also completing a very nice flavum resection to be sure about the decompression. I'm gonna show how we can identify the limits of the flavum. As you can see, we had resected the bone, and I'm completing the laminotomy, and then it's very easy to see the inferior limit of the flavum, as you can see here clearly, and the junction with the dura mater, and the upper limit of the flavum. So once identified them, I can resect the flavum, and the scars and adherents usually we find behind the flavum. Very important. So I'm gonna show some very brief cases. The first case is unilevel C4, C5, important compression of the cord was made by the 14 millimeters tube, the same technique, identify the flavum, and then completing through the medial winding, craniocaudal winding to disinsert the flavum and to complete the decompression. It's very important to don't make severe hemostasia with bipolar. It's not necessary. Usually the bleeding is stopped with L10 or something like that. At the end of the procedure, the muscle preservation is obvious, and the clinical results are very, very nice. This is the bone window of the laminotomy. You can see the post-op and the very nice clinical evolution of the patient. Sometimes, in other cases, it's important to make not just central decompression, but also foraminotomy. So this case is just to mention it and to show how it's possible to make not just laminotomies and contralateral decompression, but also focal foraminotomies when is indicated, like in this case. As you can see in the three-dimensional CT, we can see the improving in the compression, and also the windows, bone windows for the foraminotomies, very small windows with a very nice evolution. In other worst cases, it's mandatory to make a laminectomy. This is a patient with a multi-level compression in a very rigid spine, not not any instability. The patient with very bad clinical picture. This is the neutral military position, and then we can achieve winding in caudal in craniocaudal way. We can achieve different lamines to complete a very wide compression, and at the end we can see perfectly how through the 2 centimeters incision we can make a hemilaminectomy and a very good decompression, and mainly with a very good clinical evolution of the patients and with preservation of the muscle insertions and the lordosis. We published this paper associated with Roger Hartley in Cornell University to show our preliminary results until 2017 with excellent results. So the last one technique is the laminoplasty, described by Hirabayashi as an open door laminoplasty in 1977. And then Michael Wang described the feasibility to MIS laminoplasty through an initial cadaveric study, and we published some cases in their journal columna. This is the schematic procedure, and this is a case of 71 years old man with MJOA of 6, very disabled patient. This patient with not rigid spine because a subluxation of C5, C6, obviously multi-level compression, and we observe and have hyperintensity C5, C6, and the obvious deformation of the spinal cord in C3, C4, as you can see, and mainly in C5, C6. This patient had a normal bone density, fortunately, so the surgical challenges were to make a good neurodecompression, to improve the neurological status, and to stabilize the subluxation, avoiding a very painful post-op condition. So in this brief video, the last video, I'm gonna show you how in the same technique, bilateral approach, we identify the muscle bundles. Then we are identifying the facets and the laminofacet junction. It's important to make the hinge with a very small ultrasonic scalpel, and then going step by step from the head to the caudal way to put the plating, etc., preserving most of the muscles insertions. We can complete all the goals through this nice technique, even when I had to recognize this very, very, very complex. So, and the most important is the evolution of the patients without the classic painful condition. You can see here different aspects of the same technique, but the most important is the widening of the spinal canal, very nice widening, and also the improving of the clinical, taking in account the modified JOA scale.
Can we please?
Yes, okay. And then good stability, nice widening, preservation in the first 1 year of evolution, and nice fusion of the hinges in the laminoplasty. So in conclusion, the posterior microsurgical tubular approaches are useful to solve junior multilevel spondylotic myelopathy. The goal must be to complete the main objectives and agree with the EBM, but minimizing the iatrogenic damage. The feasibility depends on the interest to learn skills and to good disposition to get a slow learning curve. The understanding of the step-by-step could facilitate the shortening of the learning curves, and the knowledge of the possible complications could help to avoid them, and it's mandatory to accumulate casuistic and analyze results to understand the true clinical impact of these techniques. Thank you so much by the invitation, and congratulations again by this important event.